emergency and palliative care, which I guess is now part of Residence Health Care. Dr. White?
Hello there, can everyone hear me? Yes. Okay, terrific. I'm presenting a short talk today, Case Studies in Palliative Care. So first of all, I would like to start by introducing myself. Hello, my name is Susie White, and I am initially trained in emergency medicine. I worked in a number of emergency rooms. I trained at 3 county hospitals, LA County, Cook County, and Milwaukee County. And I got my residencies completed at both UCLA and Medical College of Wisconsin. And I was very happy practicing emergency medicine for almost 20 years now. I still pick up shifts from time to time. And I just loved the whole concept of saving lives, like getting out there, taking care of people and making them better. But what happened as time went on is things changed in the emergency room. And over the last few years, we don't have so many young people coming in as we have much older people coming in the emergency department, people with chronic disease. There was a day in the emergency department, I had 3 people there that were over 100 years old. So I would take care of them, I would do the appropriate medical treatment, but they kept coming back. And instead of my regulars being the drunks or the drug addicts, my regulars were these little old men and women from the nursing homes or from home who would come in every month to see me with whatever their chronic problem was. And I started to feel like I'm not really making a difference here. These people just keep coming back and back and back. And if anything, maybe by being so aggressive with my care, I was causing more harm than good. So it was about this time I happened, for some reason, to stumble into the field of palliative care. And I really feel passionately about it. I practice that almost full time now, and I just feel that it is the answer to the quandary that's developing in medicine as our population ages. So I'm going to try to cover just a few points with my talk with you today, and one of them is, why do we need palliative care? What exactly is palliative care? A lot of people ask me that. When should we start palliative care? And how can you, all of you here I assume are in contact with people around the end of life, how can you incorporate the concept of palliative care into what you do? So I have a number of case studies here, and this is Mrs. V. She's 83 years old, and she's really pretty healthy. She's got a little bit of diabetes, she's well controlled on diet and some oral medication. But let me tell you a little bit more about Mrs. V. She's a very independent person. She was one of the first women journalists when she was younger. She stopped for a short time to raise her family. And when her husband died, when she was only 58, she went right back to work, became the PR head of 2 major pharmaceutical companies, as well as an online gaming company, before she finally retired. So Mrs. V lives in her little apartment in New York City. She's very involved with the care of her grandchildren, and she has 2 local children that live in the area. And the reason I'm telling you this is because one of the children is a writer. And so for this case, we are fortunate to have a really beautifully written perspective of a family member as we travel down Mrs. V's timeline to see what they were thinking at that time. So Mrs. V falls in the bathtub. She comes to the emergency department, and thankfully there's no major broken bones, no broken hip. They do find that she's got a little bit of numbness in her feet, and they just decide, that's nothing we really need to treat aggressively, and she's sent home. But now the family's watching more carefully, and they notice that she really is becoming quite forgetful. And even though they put up those rails in the bathtub and they give her one of those necklaces that you can press the button and you get into trouble, she's still not quite right. They take her to her internist, and he diagnoses her with Alzheimer's disease. And as time goes on, she gets worse. She gets lost walking to the corner grocery store. She's having a hard time remembering to make her meals and to have her meals. And so the family moves her to assisted living. And she's doing okay, but she continues to decline. The family perspective. That is the thing we begin to terrifyingly appreciate. Dementia is not an absence. It's more of a non-state. It actually can be a condition of more rather than less feeling. One that, with its lack of clarity and logic, must be a kind of constant nightmare. I can hear you really well. Mrs. V is out at the movies with a group from her assisted living facility, and she becomes suddenly short of breath. She's rushed to the hospital, where they find her to be very distant, hypoxic, and in heart failure. The cardiologist feels this is due to a newly critical aortic stenosis, which means that one of the valves in her heart has been narrowing for some time, but since it wasn't causing any symptoms, they've just been keeping an eye on it. But now it's narrowed to a critical level, and she can't breathe, basically. So the cardiothoracic surgeon is called. He talks to the family, and he says, we need to do surgery right away. And really no other options are given at that point. Family perspective. My siblings and I must take the blame here. It did not once occur to us to say, you want to do major surgery on an 84-year-old showing progressive signs of dementia? What are you, nuts? My mother had enough sense to resist. Sitting in the hospital, writing panicky, beseeching, Herzog-like notes to anyone who might listen. But of course, who listens to a woman who scribbles such notes? Surgery is a success. Her surgeon comments that she can live for years now. However, after surgery, she's more confused. Her language ability has decreased, and her agitation becomes a prominent feature. And she ends up being in the hospital for 6 weeks after surgery because she's just so agitated she can't heal properly, and a psychiatrist needs to be brought in to put her on medication to soothe her anxiety and her agitation. Eventually, Mrs. V is able to return to her assisted living facility, but it's different now. She can't really play cards with her friends. She can't participate in activities. She won't go to the movies. And it might start as a little bit of palliative care because there's not a lot for us to do when you're functioning and going to work and your life is pretty much what it was. But as you get sicker and your medical options run out, medical care gets smaller, palliative care gets bigger, until there's nothing left to do medically, and then we go to hospice, and then we have our bereavement time. So, let me move on to case 3. This might be our last case. It's a good one, though. It's a happy one. Mrs. D. Mrs. D is a 36-year-old single mother of an 8-year-old girl and a 5-year-old boy. She was diagnosed with breast cancer 2 years ago, and now has metastatic disease involving her bones. Mrs. D is being aggressively treated by a team of oncologists who are exploring every single possible option to get this woman better. Mrs. D herself is quite focused on fighting this disease. She has a tremendous motivation in wanting to see her children grow up, and she's going to do everything she can possibly do to get through this. However, there's a problem, in that the metastatic disease to her bones causes her tremendous pain. And the pain continues to get worse and worse. Pretty soon, she's just not able to eat. She's not able to sleep. She spends most of her time curled up in bed. And she even has to hire someone to take her children to and back from school because she just can't get in the car. Finally, Mrs. D actually misses one of her chemotherapy appointments. And the oncology nurse calls her and says, what's going on, Why didn't you make it? And she tells her the situation. So the oncology nurse says, listen, what you need is palliative care. I want you to come in and see this team. But Mrs. D says, palliative care? That means you're giving up on me. No, I don't care how much pain I have to go through. I'm going to fight this thing. I need to live for my children. But the oncology nurse has to explain to her, first of all, palliative care is not hospice. It works right along with curative care, as aggressive as you want to be. And you need to look at it as more of an extra layer of support as you go through your disease process and your treatment. So she agrees to go in, she walks into the palliative care clinic, they take one look at her, she looks awful, and they hand her some pain medicine, some good strong pain medication, and they put her on a regimen. She goes home, and within 2 days her pain is well controlled. She can sleep, she can eat, she can interact with her family, and most importantly, she can make it to all her chemotherapy appointments. So she continues her chemotherapy, the scans show excellent response. Mrs. D's tumors shrink enough that we're able to actually taper down on her narcotics. And now she's a big fan of palliative care. She walks around and says, you can't do this without palliative care because you can't get through this treatment without that extra help. So that's a good story. I have a lot here about when you should start palliative care, and basically the answer is early, and why you should start palliative care, and that's because it's a really great thing. But I do want to talk about, before I finish up here, one really important study that has really moved palliative care into the forefront of medical practices everywhere. And this happened in 2010 at Massachusetts General in Boston. And they had 151 patients who had non-small cell lung cancer. And they split them into two groups. So let's say this group here had the oncologist, very aggressive care for as long and as much as they wanted or needed. And this group here also had very aggressive oncologic care, but they were also told they must go to the palliative care clinic to work alongside with them. So they looked at these two groups, and what happened is when they started measuring things, I have to find my data here, they found that the quality of life in patients who had palliative care was higher. That's not a big surprise. It was a little bit, but it was statistically significant. They also found that there were fewer depressive symptoms. This group here, who only had oncologists, about 38% of them were significantly depressed. And this group, only 16%, so that was good. And they also found that they had less aggressive care. The group who had palliative care in general opted for hospice more often, and the group here who had just the oncologist tended to have chemotherapy all the way up until the last days of their life. So these are things that are not terribly unexpected with a good palliative care program. But the surprise was that when you looked at the longevity of these two groups, even though this group here had more aggressive care, they died 3 months earlier than this group. Now, if you know anything about non-small cell lung cancer, it's a bad cancer. People don't live a year after diagnosis. And there's very little that we've been able to find medically to extend people's lives for a month or maybe 6 weeks. But 3 months, that's huge. And to think that something as relatively simple as palliative care could extend life just opens up all kinds of thoughts about how supporting our patients, not just physically, but emotionally, spiritually, opening communication can actually save lives. For a little longer. I have, my last case involves someone who had a lot of pain, and basically is because she had a lot of spiritual distress. And that was just to remind you that there are many components to physical suffering, and that not all of them can be fixed with a prescription pad, and that the reason that palliative care is multidisciplinary is because suffering really is multidimensional. I look at what the families wanted at end of life, and it touches me that one of the things they just wanted was just to be listened to. You know, we walk into the room and we tell them all the data and maybe sometimes they just want someone to sit there and listen to them and to remember their loved ones. And so there's no reason why any of us in this room can't do that. Because the end of life absolutely can be a time of great meaning, a time of great faith, of great love, of reconciliation. And we need to look at that instead of death as the enemy. Death is a natural part of what we're all going to go through. And we need to just help our patients go through that period of their life and have value at the end of their life. So, unfortunately I don't have my great slides here, but anyone have any questions? All right, we'll wrap it up because I hear stomachs grumbling. Maybe it's just mine.